Hello, everyone. I hope everyone enjoyed the keynote luncheon. We are kicking off afternoon with a popular topic, what's new in breast cancer? We are fortunate to have Dr. Anne Kristen Buteau with us, and she will guide us through her research today. Dr. Buteau is a breast medical oncologist and assistant professor of medicine at the Lardner College of Medicine. She completed her fellowship from Dartmouth College of Medicine. She is passionate about breast cancer care and global health. She led research projects in Haiti and helped create international education programs for cancer care. Her work focuses on improving systems so patients don't fall through the cracks. She's also fluent in French and Haitian Creole. With that, I welcome Dr. Kristen Buteau.
Thank you for that lovely introduction, and thank you to the organizing committee for inviting me here today. So I started about a couple of weeks ago here at UVM, so this is a welcome party for me. So I'm going to talk about what's new in breast cancer, and essentially I'm just going to talk about some studies, publications this year and maybe last year that I found to be interesting, and I've centered them around three themes that we're going to talk about. So first, okay, and here we go. This lovely person is a dear cousin of mine, beautiful person, inside and out. She was diagnosed with breast cancer in her 30s, and she shared her journey on social media. She had 75,000 followers on TikTok, 1 million likes, and I played at times her cousin, of course, but also her intermediary between herself and her doctors, and to kind of translate the medical jargon at times. And I witnessed firsthand not only the toll of the disease, the toll that it took on her, but also the impact of the chemo medications and the immunotherapy and all of that, that it had on her, and it has on multiple of my patients throughout fellowship. And I have to say, at the beginning of my journey in cancer care, I was more interested in survival, improving, having people live longer, may it be 3 months, 6 months, 12 months. I was very excited about the new treatments coming out, and I thought when we were discussing with patients and the attending was present, that why wouldn't someone take medication that would give them more time with family? This experience with my cousin had a deep impact on me and caused a change. And I am more interested, I wouldn't say more, but as interested in quality of life than life-prolonging measures. So I say this as a background to say yes to quality of life, and that's going to be one of the themes that I'm going to talk about today. But I think going over some of the recent research publications over the past couple of years, quality of life is one of the themes that I think the field is embracing right now, alongside de-escalation, meaning studying having less intensive chemo regimens and with similar outcomes with patients, and also precision. So today, all of the studies that I'm going to talk about are centered around these themes: quality of life, de-escalation, and precision. And I put this picture out here just in case you weren't convinced that my cousin was amazing. Look at these boots, the yellow boots. Fashion sense impeccable. Okay. So here's the agenda for today. Under quality of life, we're going to talk about 2 studies. Precision, the SERENA-6 study, Destiny Breast 09, the ASCENT trial, and for de-escalation, the NeoCARP phase 3 trial. So first, I just want to be sure that we review some terms. We have three big subsets of breast cancer, ER positive, HER2 positive, and triple negative. And this is me not getting into the molecular stratifications. So 3 groups. ER positive breast cancers account for the most common type of subset with 70 to 80% of patients. And HER2 positive, 15 to 20%, including patients who are ER positive and HER2 positive, and 15 to 20% for triple negative breast cancer. Let's remember the themes. Okay, so we're gonna get into quality of life first, but first, as a background, I wanna say it's the most common type of subset of breast cancer, and endocrine treatment is the cornerstone of treatment. Endocrine therapy is the cornerstone across all stages, early stage all the way through metastatic disease, meaning stage 4 when the cancer has gone out of your breast and into other organs. It's a pretty good medication. It saves lives, and in the case of early stage breast cancer, it prevents the cancer from coming back, so it prevents recurrences. Despite that, it's a pill that you take at home. You don't have to come to the hospital all the time. About 1/3 of patients stop the medication because of side effects. Some of the side effects include menopausal symptoms, so hot flashes is a big one, joint pain. In some cases, it can cause mood changes. So patients don't stay on this medication despite it being a pretty good one. So this is the first study I wanted to mention. Elinzanetant for vasomotor symptoms from endocrine treatment from breast cancer. I mentioned earlier one of the complaints is really bad intractable hot flashes. So this study included women 18 to 70 years old with moderate to severe vasomotor symptoms. And they were randomized to getting once daily elinzanetant, which is an NK inhibitor, from 52 weeks versus daily placebo for 12 weeks, followed by once a day elinzanetant for 40 weeks. And the primary endpoint was the change in the mean daily frequency of moderate to severe vasomotor symptoms. So we just want to see if you're getting less hot flashes on this medication. So it did work. Patients who were on this medication had about less than 6 hot flashes episode per day compared to those who were not on the medication. And this was the case after 4 weeks of use, and again at 12 weeks, so after 3 months. There were a little bit more adverse effects in the elinzanetant group, mostly fatigue, somnolence, but the medication led to a significantly lower frequency of vasomotor symptoms associated with endocrine therapy. So the second study I want to talk about is the TRADE study. So the drug abemaciclib is used with adjuvant endocrine therapy for high-risk, node-positive, hormone receptor-positive breast cancer patients. So a lot of time patients who had stage 2 to stage 3, so breast cancer in their breast, and that went to their lymph nodes. And when you add this medication to endocrine treatment, it decreases the risk of the cancer coming back. And the landmark study, the Monarchy study, showed that led to approval of this medication, showed that about 25%, so a quarter of patients stopped this medication early. And about 18.5% stopped it because of adverse events, those being low cell counts, so anemia, low white blood cells, you're more at risk of getting infections, and diarrhea. Diarrhea is a big complaint on this. And about 43% of patients required dose reduction. So this study is a prospective study, so patients were enrolled. It's a single arm, and the question was, does a dose escalation strategy improve drug tolerability? Meaning, instead of starting you on the highest dose, 150 milligram twice a day, what if we were to start the patients on a lower dose at 50 milligram twice a day for 2 weeks, and then escalate every couple of weeks until you reach the recommended dose? And the primary endpoint was the rate of of stopping the abemaciclib for any reason, or the inability to reach or maintain the higher dose. Meaning if a patient is coming in, they're at 100 milligrams and they're getting diarrhea, you can't really escalate at that point. So the primary endpoint for this study was met, and about 70% of patients reached that adequate dose of 150 milligrams and maintained it at 12 weeks, compared to the Monarch study, the landmark study. So 93% of patients were continuing this medication at 12 weeks, and also, the patients had reduced incidence and severity of clinically important toxicity, notably diarrhea. So I think it's a great strategy, especially for older women who may have baseline gastrointestinal issues. Instead of starting at the higher dose, there's data to prove that you can safely start at a lower dose. So we talked about quality, so meaning leveraging strategies to have the patient stay on the medication and decrease some of the side effects. I want to talk about precision now. Precision, when I think about it, it's basically using molecular information about the drug, the drug, yes, the tumor biology, and to leverage that information to have a specific treatment and not use the hammer that maybe we were using 50 years ago where your common chemotherapy was used for every patient coming in. So the first study I want to talk about is the first-line camizestrant for emerging ESR1 mutated advanced breast cancer. This is the SERENA-6 study. So a lot of patients, when they use the standard of care endocrine treatment, so patients with advanced metastatic breast cancer, we use aromatase inhibitors, so letrozole, for example, plus a CDK4/6 inhibitor. Sometimes the cancer outsmarts the medication that we use, and patients develop mutations and resistance to the treatment. One of the ways that the cancer can outsmart everyone is basically through this acquired mutation in the ESR1 gene. And the patients who have this mutation, they're less likely to respond to treatment with the aromatase inhibitor, so letrozole, for example, endocrine treatment, and the CDK4/6 inhibitor. So this trial is very interesting because it's the first one, and not the first one, but I would say a landmark in some cases that use circulating tumor DNA, what we call liquid biopsy, and to change treatment based on that information without having to check imaging to see if the patient is progressing, if the cancer is progressing or not. So camizestrant is a next-generation selective estrogen receptor degrader, and patients with advanced breast cancer with ER positive and with this mutation, the mutation was assessed through circulating tumor DNA, so the liquid biopsy. And all of the patients had received at least 6 months of the first-line therapy of the aromatase inhibitor plus CDK4/6 inhibitor. And when the patient have this mutation, even if on imaging they're not progressing, they stratified the patients into 2 big groups. Either you continue with the CDK4/6 inhibitor and the aromatase inhibitor, or they switch you to this new medication, the camizestrant, with the CDK4/6 inhibitor. And so the primary outcome was investigator-assessed progression-free survival. So here we can see in green, it's the camizestrant group, and in purple-ish, I would say, the aromatase inhibitor group, so the standard of care. Patients in the camizestrant group had a progression-free survival of about 16 months compared to 9 months with the aromatase inhibitor. Progression-free survival is the time between when you start treatment and the cancer progressing or the patient dying, for example. So switching to this drug with the CDK4/6 inhibitor after having this acquired ESR1 mutation led to a significantly longer progression-free survival. At this point, we don't know if that's going to translate into overall survival. But it's pretty interesting. But of course, there are some questions, especially this liquid biopsy is not widely available in all hospitals, especially rural hospitals, and it's still expensive. And checking it every 3 months, I think there are some resource barriers to that. So the next trial, the Destiny Breast 09, I had to talk about it because it's changing the first-line therapy algorithm in HER2-positive metastatic breast cancer. So about 10 years ago, the Cleopatra trial established THP, so taxane plus Herceptin and pertuzumab as the first-line treatment for patients who have breast cancer, HER2-positive breast cancer. I want to pause a little bit to say how, even with that, how far along we've come. In the 90s, having HER2-positive breast cancer was a death sentence. Patients were living about 1 to 2 years, so the median survival. And then fast forward with the development of these targeted treatment to the HER2 receptor, patients are living longer, 3 years, and even beyond 5 years. And Cancer Talk, this is amazing. So see, I'm interested in quality of life, but still interested in overall survival. So this trial, it was randomized, meaning we had 2 groups, and patients who were previously untreated HER2-positive advanced metastatic breast cancer. It had 3 arms, trastuzumab deruxtecan, which is I think the hottest thing right now in breast cancer. And it's an antibody drug conjugate. And I put it under precision because it still targets the HER2 receptors on your cancer cells, and it delivers a chemotherapy payload to the cancer cells. And theoretically, that makes it more specific, and you don't necessarily attack the good parts of the non-cancerous cells in your body, but you still get some side effects with it. So the 3 arms were the TDXD, also called Enhertu, plus placebo, versus Enhertu plus pertuzumab, versus the standard of care, which is chemotherapy, and trastuzumab, pertuzumab. The primary endpoints were progression-free survival, and the secondary endpoints were overall survival, objective response rate, and duration of response and safety. So they haven't yet compared the trastuzumab alone versus the THD, but they did at this interval compare the Enhertu plus pertuzumab versus THP, which is the standard of care. The median progression-free survival was 40 months versus 26 months, which is pretty compelling. The objective response rate was 85% versus 78%, and the complete response rate was 15 versus 8%, all favoring the Enhertu. And overall survival analysis, it shows that there's a trend towards favoring Enhertu, but at this point, the data is still immature, so we can't really speculate on the outcome. So the significance of the Destiny Breast 09, this was presented at ASCO this year. It led to a significant improvement in progression-free survival and supports this line as the new first-line standard of care treatment for metastatic HER2-positive breast cancer. And it signals a shift around the theme I'm talking about, chemotherapy or lower chemotherapy regimens, and it led to a breakthrough therapy designation granted by the FDA. Just means that the FDA is going to work with the researchers to kind of streamline this through the approval procedures. Now, the other trial I want to talk about, and we're still under precision, the ASCENT-04, also called Keynote D19 trial. Now we're talking about triple-negative breast cancer patients. It's a phase 3 first-line trial in PD-L1 positive breast cancer. PD-L1 is essentially, I want to say, a marker that tells us whether you're likely to respond or not to immunotherapy in this setting. And if your PD-L1, your CPS score is greater than 10, we would use immunotherapy in this setting. So The standard of care currently is pembrolizumab. So if your PD-L1 score is greater than 10, is equal or greater than 10, and chemotherapy. And so they wanted to compare sacituzumab govitecan, also called Trodelvy, to the standard of care regimen. And they enrolled about 400 patients with untreated PD-L1 positive metastatic triple negative breast cancer. And patients were randomized 1-to-1 to each group. And the primary endpoint here again is progression-free survival. So the median progression-free survival was about 11 months for the sacituzumab group versus 7 months for the chemotherapy and pembrolizumab group. Overall survival, the data is still immature, but there's a trend favoring this new line of treatment. And the objective response rate was about 60% versus 53%. And the median duration of response was 16 months for the SASI and pembrolizumab and 9 months for chemo and pembro. So it is the first phase 3 trial to show that antibody-drug conjugates, so ADCs, plus immunotherapy are superior to chemoimmunotherapy and PD-L1 positive metastatic triple-negative breast cancer. And this supports this regimen as the new first-line standard of care for this population. So lastly, we're going to talk about de-escalation, although I think I alluded to that a bit. The NeoCARP trial, it's a phase 3 trial. And here we're back to talking to HER2-positive breast cancer, but early stage, patients who don't have metastatic disease, meaning the disease is in your breast and your axilla, your stage 2 to 3. And so the standard of care for these high-risk patients, it's to give chemotherapy before surgery. And we use 4 drugs in that setting, taxane, carboplatin, Herceptin, and pertuzumab. So here it's a regimen for some patients, it's difficult to tolerate, and you get a lot of cytopenias, meaning your white blood cells go down, your hemoglobin goes down. And so they wanted to see if we took out the platinum, so the carboplatin, so less chemotherapy, or is it still safe, or are we getting the same outcome? And here they wanted to see if your tumor is responding, so pathologic response. So the carboplatin group, the pathologic complete response rate was about 65%, and the no carboplatin was 64%. So it's not a big difference. And what this tells us essentially that it could be safe to de-escalate in certain settings. If there's an older patient coming in who has like a poor, I wouldn't say older, I don't want to discriminate, poor performance status or already has comorbidities that you can predict they're not going to tolerate the heavy 4-drug regimen, then this is an alternative that one could think about. So omitting carboplatin in this setting is safe for selected patients, and it supports de-escalation of chemotherapy in HER2-positive early breast cancer. And the results guide efforts to minimize toxicity without compromising efficacy. So this is, I think, the last trial I want to talk about. This, and here I want to emphasize, yes to precision, yes to quality of life, yes to standard of care in some cases, but it has to be for all. I think we're living in a world where there are more and more left behinds. It's a very exciting time in all of the sciences, I think, even when you think about artificial intelligence, and we have to make sure that working class people, especially those who are underinsured or uninsured, can still benefit from all of these exciting new developments. So this is a registry data. This is a real-world observational study of about 5,000 patients with hormone receptor positive early breast cancer. So the breast cancer hasn't gone to anywhere else, and they studied the genomic risk using MammaPrint alongside clinical outcomes by race. And the purpose of this study was to assess genomic test utility across diverse populations. And here I'm going to talk about white versus Black women in this setting. And so MammaPrint accurately predicted the 5-year distant recurrence-free interval. So basically, this is a genomic tool. It looks at about 70 genes in the cancer, and it spits out a risk profile. And patients are stratified. They can be either ultra low risk, or high risk 1 or high risk 2. And the higher risk, the more likely you are to benefit from chemotherapy and to prevent the cancer from coming back. There's minimal chemotherapy benefit in low and ultra low risk groups. And this study found that there were no significant disparities in genomic risk prediction between racial groups, meaning this tool works for diverse population, may these population be white or black. So what's interesting here, I wanted to highlight, Black patients are more likely to be high risk when you use this tool. So about 61% in this registry, 61% of Black women had high risk 1 or 2, and about 52% receive chemotherapy. Remember, the higher the risk, the more likely you benefit from chemotherapy. Versus for the white population in this registry data, those about 44% were high risk. Remember, 61% for the Black women, and 40% of the white women receive chemotherapy. All of this to say that when we have both populations represented and who are at high risk, white women in this registry data were more likely to receive standard of care treatment compared to Black women. And there are different reasons for that. Sometimes a patient refuses the chemotherapy, or sometimes it means that maybe insurance didn't cover it. Sometimes it means that the doctors then talk to the patients about the specific treatment. So we don't have to get into the specific causes, but just to say that Black women are less likely to receive standard of care in this registry data. Here, I just want to highlight the second portion. Among patients who were treated with chemotherapy, CTs for chemotherapy, the outcomes were the same. So, and again, I want to go back to this. We have a lot of exciting tools. We have to make sure that standard of care and all of these new tools are available for all people. So equal outcomes for Black and white women with proper guideline-based therapy. So, summary, I've been talking for a few minutes. We talked about quality of life with the elinzanetant study and the TRADE study. Precision medicine, SERENA-6, DESTINY-09, and ASCENT-trial, and de-escalation with the NeoCARP study. And lastly, what's new in breast cancer? There's definitely a shift toward personalized, tolerable, and effective care. And by addressing symptom burden and leveraging precision tools and exploring de-escalation strategies, these studies that I talked about inform the path to smarter and patient-centered oncology. But old questions linger, or standard of care treatment, all these different tools, are they available for all people? So, thank you.
Wonderful talk, Dr. Buteau, and not an easy task with so much research that's going on in the world of breast cancer. We have a lot of de-escalation trials in breast cancer available at UVM, and I was wondering if you could share, you were the Scarlet, Offset, Low TAM, and wondering if you can share with the group your experience and how you talk about these trials with patients, not only as an opportunity to inform how we treat future generations of breast cancer patients, but also how that's an opportunity for the patient themselves.
Right, thank you, great question. And yes, we have a lot of trials here at UVM that are exploring de-escalation themes and even precision medicine, and I'll talk about a couple. We have the Low TAM study with patients postmenopausal patients who have early stage breast cancer, and if you have a low oncotype, there's a possibility that you may not need chemotherapy, so not chemotherapy, you may not need radiation therapy, and you may be getting a low dose of tamoxifen versus the regular aromatase inhibitor. So in that case, that's the de-escalation, so talk about it to your providers if you're coming our way. Another exciting trial for premenopausal women is the OFFSET trial for women with this gray area of their oncotype score, which is a genomic test that we use for women with early stage breast cancer. If they have an oncotype between 16 and 25, we don't know if they benefit from chemotherapy versus ovarian function suppression and aromatase inhibitor, so we're kind of exploring that. Maybe not everybody should get chemotherapy. Another trial for triple-negative breast cancer patients, they usually get immunotherapy. It's called the Optomice, if I remember correctly. And so these patients get chemotherapy and immunotherapy before surgery, and after surgery, depending on their pathology, we continue with pembrolizumab usually. So we're exploring, do patients really need to stay on pembrolizumab for a year? So a lot of exciting new studies. And there are even more, so please talk to your providers if you're coming that way.
This is a question from a Zoom attendee. I am post-treatment for HER2 plus / ER plus breast cancer. Now I'm only on daily exemestane. Are there additional new measures to prevent recurrence?
So there are, in that case specifically, but it's without going into details, it's going to depend on the stage and the risk profile of that patient. And in certain cases, they can add another drug called neratinib. In the case specifically of ER positive, HER2 positive breast cancer. It has some side effect, but the idea is to prevent the cancer from coming back in high-risk patients. So I would say we would have to know more about like the specific stage, et cetera, to see if that patient could benefit from it. But staying on the aromatase inhibitor is already a plus at this time.
Can you talk about the breast cancer vaccine that I've heard about on the news, and is that coming to Vermont?
I don't think that we're there yet. I know there are a lot of exciting studies about it. I don't think it is approved yet. It's still going through like approval, and then I think we still need to have more data. But to my knowledge, no. But if someone...
There's a vaccine trial that's being looked at for high-risk patients with germline BRCA variants. I don't know if that's the research that you're speaking about. Say that.
I actually don't know specifics about that. Our patients ask me a lot about... Hello. My patients ask me a lot about this breast cancer vaccine because they've seen it on the news.
Yeah.
And so most of the information I get about this vaccine is from the patients. So all the big words is not... I don't know what specifically you're talking about, but it's been a buzz in the clinic.
Okay, yeah, well, there is a trial that's looking at a vaccine for breast cancer prevention in patients with underlying germline BRCA variants, but I would definitely need more specifics to know how to answer their questions more directly. I'm not aware of another vaccine trial right now.
Thank you.
So I have metastatic breast cancer and have for 8 years, and I am thrilled to hear you talk about these de-escalation concepts. I have advocated the de-escalation concept with my oncologist since the beginning. There were times when she did not really agree with my desires, but she accepted them. And I think the more that we can help people stay well and not overdo the toxins that you put in our bodies to help us stay well, the better everyone will be. So thank you.
Thank you. And I'll add that it's sometimes hard for us physicians to decide if we want to de-escalate without having any data, and that's why it's so exciting to go through these trials. When we know that in a specific setting they've tested and the researchers see that it's safe to get rid of one of the chemo drugs or maybe stop them, we're more comfortable. But without, in a data-free, and when we don't have this specific data to tell us it's safe to do that, we get anxious. I get anxious about it.
So this could be a whole nother lecture, but I have a question about like early breast cancers, like DCIS. Like I had DCIS in 1998 and was treated here with 2 lumpectomies, 7 weeks of radiation, and then 5 years of tamoxifen. But I think that has changed over the years. Is that correct?
Well, I think there are more and more data coming, and we tend to stratify patients into their risk profile, whether they had DCIS or stage 1, stage 2, stage 3 breast cancer. It's overall the same type of treatment that we offer: breast conserving surgery, meaning the lumpectomies, and radiation, or a mastectomy without the need for radiation in most cases, and the adjuvant, meaning the endocrine therapy after radiation. And for DCIS, it's usually 5 years. But when we start to have higher stage patients, we tend to, when we have higher risk patients, we tend to think about, okay, is it safe to give you 5 years of treatment? Or in certain cases, we can even push it to 7 to 10 years. Let's say if you had positive nodes in breast cancer, usually not DCIS in your case. So that may be changing. And I think there's more and more information coming out about that.
Thank you.
Okay, it's just a comment, and I think it's from someone who works at the health center here. I think there may be trials for vaccine for triple-negative breast cancer. I know of one at Moffitt in Florida. No plans to have those in Florida. As Dr. Landry and Dr. Buteau mentioned, vaccines and breast cancer are investigational still. And then there is another question. How is your cousin?
She passed away a couple years ago, unfortunately, yeah. But her TikTok page is still on, and yeah, and she's fabulous forever. Thank you for asking.
All right, we're going to take a couple more questions.
Thank you for your presentation. Do you know the rate, with the aromatase inhibitors, there's so many side effects, the bone pain, the insomnia, the list goes on. Mm-hmm. The reoccurrence or the rate of tamoxifen versus the aromatase inhibitors on early breast cancer?
So it's going to depend on which population we're looking at, premenopausal versus postmenopausal. In the case of postmenopausal women, the aromatase inhibitors are usually the first go-to. But again, as I said, there's a trial where we're exploring the low TAM, the tamoxifen in that population. And for women who are premenopausal, the higher risk you are, meaning when we look at the biology of your cancer, we look at the pathology, we look at the staging, that the cancer spread from your breast to your axilla, we tend to be more aggressive, for lack of better words, and instead of recommending tamoxifen in that case, we recommend the aromatase inhibitor, and in that case, we have to do ovarian function suppression with an injection to suppress your ovaries. So I would say the aromatase inhibitors are better at preventing the breast cancer recurrence. I don't know if that answered your question specifically.
Right. Oh, it's online.
What is new for HER2 low hormone positive treatments?
I talked about in HER2, I think it's the hottest thing around. So HER2 low, it means that patients that we considered to be HER2 negative a few years ago, this is when you check with immunohistochemistry, they're either 1+ or 2+, so they can be low or ultra low, previously considered negative, and there have been studies along like the Destiny studies that have shown that patients who are HER2 low can respond to HER2 targeted treatment. So again, it's going to depend. It's usually we're talking about advanced stage metastatic. So these patients can benefit from that antibody drug conjugate as well.
All right. Thank you so much, Dr. Buteau.
Thank you. Thank you, everyone.
Breast cancer leading the way. Just on our closing plenary, Sugar, Soy, Science, Myths and Truths in Integrative Medicine by Dr. Amy Littlefield will start at 3 p.m. And it will be held in Silver Maple. So please join at 3 p.m. here. Thank you.